All right, Dr. Maureen Mavrinac, thanks so much for taking some time to talk to me.
Thanks for having me.
Of course. Well, I get an article on a weekly basis, and I give a little bit of commentary on storytelling specifically and how storytelling ties into whatever the article is talking about. And for this week, I read your article on shared medical appointments, and I thought rather than me doing my usual thing, since I know you, it'd be wonderful just to get your thoughts kind of live and in person in this format on how that came about and the kinds of things you've seen in that work as far as patient provider communications, and just getting the inside track on what happened. So, I mean, in the article you mentioned that you came across shared medical appointments when you were working in Los Angeles in 2011. So would you just tell me a little bit more about how you became aware of this as a model for seeing patients?
Right. Yeah. So actually, I started using it in 2011 when I was core faculty at UCLA, but I actually came across it earlier than that. It was probably in 2000, hard to remember exactly, but 2007 to 2009. And I did it because I realized as I was seeing patients myself, that I kept saying the same things over and over again regarding diabetes. And so I began to realize that the model of medical care that we had, where there was this 15-minute appointment, it just didn't seem to be, I wasn't able to really bridge the gap between myself and my patients. So I began to look at different models of care that were perhaps doing it more successfully. And so what I discovered was there was a clinic in Denver called Clinica, and they had a large Latino population, and they were using these group medical visits or shared medical appointments for everything from diabetes care to prenatal care. And I was fascinated. And so I remember meeting the then medical director of the clinic at a conference, and I talked to her and I looked at their website. And then I just thought, well, there's no substitute for just getting on the bike and trying to ride it, even if it's wobbly. And so that's when I started to kind of implement it at a clinic I was working at with residents and medical students as part of the UCLA Family Medicine Residency Program. So that's sort of how I got started in it.
And then, sorry, go ahead, please.
Yeah, and then I took it to another practice that I went to, which was in the Central Valley, and that's where that article came about.
Okay.
Yeah.
And even when you were in Los Angeles, was it mostly with diabetes patients?
Yes.
Okay.
Yes. Exclusively. Yeah.
Okay.
And I would have to say a Latino background.
Okay.
Or Latinx. Yeah.
When talking about the model of that shared appointment, one of the things you mentioned in the article was that people who come to these shared medical appointments share their experience, strength, and hope, which is something kind of directly out of a 12-step program. And one of the things that's so interesting about this as a model for physicians and healthcare providers seeing patients is that, correct me if I'm wrong, but the driver behind this kind of this kind of patient-provider interaction is really trying to change people's behavior, which is something that it's really kind of hard to do in the narrow sort of the consultation that you get with the physician on a normal basis. And like you said, the kind of standard 15 to 20 minute model. And you mentioned this a little bit in your article, but can you tell us a little bit about the kinds of stories that people were telling about themselves? And how things went from in a one-on-one environment to all this, I want to change and I understand the change is necessary, but this is hard. And how did that kind of self-narrative change to I can actually do this and I'm making this kind of change in that shared medical appointment?
Right. Yeah, that's a great question. One tiny example, when I was in Los Angeles and working with a group at this residency clinic, we had the power of the peer, I would have to say. We had one patient, one gentleman who shared that he liked to eat 8 tortillas with each meal, and he was uncontrolled diabetic.
Mm.
And a woman across the table just zeroed right in at him, and she said, "You don't have to do that. I used to be like that too." And there was something so powerful in that moment. I could draw a picture of my plate, the healthy eating, the portion control. I can talk about all the reasons why one needs to eat in a certain way. But at the end of the day, that particular moment with that peer was, I think it was probably one of the most powerful. That's a good example. There's another thing that I have to share with you that it's interesting. Last evening, I actually read an article, just came out today in the Journal of the American Medical Association, and it was written by Abigail Zuger, who is a reviewer for the New England Journal of Medicine for medical articles. Mm-hmm. And she talked about, and I had it, Lance, I had to write, or at least write or refer to some of the things that she said. She was talking about the title of the article was "Preventing a Pandemic's Toll, We've Been Here Before." And so basically talking about how to convince people to accept the COVID vaccine. But she mentioned it in the context of the HIV epidemic in the 90s. There was a period when HIV became not a death sentence, but actually a chronic disease, and that was in 1996 with the advent of the protease inhibitors. And I actually was a young clinician then, and I remember caring for patients like that. And we literally pulled people back from the jaws of death. You would have these folks that were very, very compromised, immune compromised, and with these drugs, they actually began to thrive. But she said there was one particular patient, she said, and this is what I'm going to quote her, "I taught him the science till I was blue in the face. I showed him the data. I drew him the curves. I told him I understood his reluctance. Nothing worked." But she stuck with this guy. And ultimately and finally, the poor patient contracted an a disease that's very common in the immunocompromised, pneumocystis pneumonia. It's a benign organism to people that aren't immune compromised, but in an HIV patient who's untreated, it was really devastating. And she said that he was admitted to the hospital. I have to read this because it's so profound, and I think it'll illustrate things. Is it okay?
Oh, please, go ahead. Yeah.
He said he was admitted to the hospital for his final weeks and developed a friendship with a man recovering from severe AIDS-related pneumonia in the next bed. This roommate taught my patient more in a few hours than I had managed during the previous 2 years. I doubt very much it was the science they discussed, or the data, or the curves, and the risk-benefit analysis, but something changed my patient's mind. He died with a little paper cup containing the second or third dose of antiretrovirals on the bedside stand. I suppose you could cast him as some kind of postmodern hero for living and dying entirely on his own terms. You could turn me into some kind of saintly clinician for continuing to sit with him despite everything. You could probably compose a whole satisfying tragic healthcare opera of the two of us. But obviously, there were no heroes on that long ago stage, only a pair of confused, well-intentioned humans from two different worlds struggling to comprehend each other's fears. What a huge waste that we still haven't got any better at that vital piece of clinical medicine. So that's kind of sums it up. And it was interesting that I read that just last night.
Yeah.
Yeah.
I think I saw a quote from that just floating around somewhere on social media. And I think I saw that quote that you read to two people trying to understand one another's fears. And that's it's a sort of big bookmark for our current moment. I mean, especially with COVID, I mean, just trying to understand mean, people's fears about COVID and the vaccine, and I mean, news coming out today about boosters and just everything else going on in the current moment. It just when you're face
Yeah.
to face with somebody, I mean, whether it's a patient provider or just two patients talking, like trying to understand one another's fears. I mean, the article's right. We've definitely been
And
for.
and to bridge that gap and to communicate. And I still struggle with that. I this week have been dealing with folks that I'm trying to reach. And how do you bridge that gap? And so to kind of come full circle on the shared medical appointment, there's nothing. I mean, it's another tool in our toolbox as medical clinicians to be able to use that model. Some people don't like the group. They prefer one-on-one.
Sure.
But even if you don't like a group, there's nothing more powerful if you have a chronic disease than someone else who's been there, done that.
Right.
And I think that kind of goes back to the whole experience, strength, and hope model of the 12-step program.
Right.
Yeah, yeah.
When you've been talking mostly about the and about the point of view of the patient getting help and the patient getting well, but one of the most surprising things in the article is that you've talked about how this kind of shared appointment and I mean the model and the changes it can make are really, I mean, beneficial to physicians and providers too. I mean, can you talk a little bit about how this kind of reinvigorated your practice of medicine too?
Right. Thank you. Yeah, great question. Again, I think originally I was struggling. Probably some people would say mid-career burnout back years ago, and I just was looking for a different method
Sure.
to reach patients, and I was frustrated, and so that's when I discovered this model, and was reading about it and the success that the Clinica center had in Denver, and when I started to use it, there was something about it. I felt sitting down. I'll never forget this, sitting down in a clinic room in a county clinic in Los Angeles with these folks was so, they were all seeing me as their physician, and they could all relate to me as their physician.
Right.
And I was there with them sort of in solidarity as part of that group. And I don't know, there was something transformative. I wasn't standing up, preaching. There's a little bit of education. The model is it can be you can do a little education in it, and we did actually. We did education and sort of a quiz type thing or a contest. We'd make it fun.
In the group, I mean, for the
In the
participants.
group, yes.
Okay.
Is it true or false?
Okay.
Take vital signs. Yeah, and then sometimes take blood sugars and that sort of thing. But then at the end of the day, we would talk about how people were dealing with with the disease. And there was something very powerful for me about being a member of that group, and just listening and being there to support and having them. It was a whole different exchange than coming into an exam room in that very
being the white coat in the room, being the the physician, the authority in the room. Yeah.
Right. The expert. So there was something very powerful about being part of the group, and it became more intimate. And I think that there was sort of, I guess, I don't know much about theater, but is there the fourth wall or something when you break? Yep. What is, so you break it and you come into the audience?
Talking to the audience. I mean, so the fourth wall, I mean, if you're in a traditional stage environment, there's an audience looking at, I mean, the room, I mean, and, the actors are pretending that they're in a room, even though there's one wall that's, transparent. We're pretending it's transparent so you can see into people's lives. But yeah, it's been actually being able to sort of break that and that, barrier coming down of, I'm not the person who's performing and telling you and disseminating this information. All of a sudden, if that fourth wall is not there, that, the audience, if you want to talk about the patient like that, and the physician who's, there on stage, giving this information or being, like you said, being the authority in the room, that all of a sudden that there's a real dialogue back and forth. Yeah, absolutely.
Right. Yeah. And that creates an opportunity created an opportunity for me to be creative. So I mean, I would do things like go to a big box store and get a veggie tray and schlep that in there and for healthy snacks. So really trying to make it a meeting, and that was, and then figuring out how we would what we would do, how it would be structured. It was the time we would spend would be, we weren't given very much time, but maybe a little over an hour. So,
Sure.
how do we get folks in? We had maybe 10 to 12 people. So I would have the medical students. In that venue, it was medical students. When in the article, the venue was, I was working with health educators. So we would and medical assistants, and we would take their vital signs, and then everyone would sit down and we would talk about some educational point, discuss lab results, what the meaning of those were, and that was so it was every time I had to do a group, it was really improv. I mean, how do I reach in if somebody's sitting there with their arms folded,
Right.
It's a whole different element to sort of I don't want to say running the group, but yes,
Right.
but managing the group.
Right. If there's one other person in the room, or maybe, somebody who's in some context translating, or a family member who's there with you, in a traditional one-on-one consult environment, I imagine that's still improvisation. I mean, that's its own little piece of theater.
Yes. Yes.
To talk about it like that. But now in a room full of people, all of a sudden, I mean,
Right.
taking that one-on-one environment, all of a sudden, I mean, like you said, somebody across the room might have something meaningful to say. And like you said, just facilitating that group. I mean, it's not just the improv of the one-on-one. All of a sudden, you've got a whole array of people to surprise you, I guess.
Exactly. You hit the nail on the head. That's exactly what it was. And so that really was extremely, I guess there was always a little bit of jitters before, but it
Sure.
was very fulfilling, if it was successful. And then the personal comments of people, the patients,
Right.
that was really satisfying.
When you mentioned the word creative, I mean, and something as simple as grabbing a veggie tray, bringing
Right.
that into into the group. There's something about food. When there's food present, it sort of relaxes people, and there's something to do rather than just sit there and, I don't know,
Right.
stare at one another across the room. There's something kind of tactile, and we're eating. I mean, that word creative is not something that most people really associate with medicine. And I think the general public, and even I think it's fair to say a lot of physicians wouldn't say that medicine is an inherently creative practice, because people go to a doctor, I mean, go to a provider wanting an answer, wanting a diagnosis, a medication, something like that. And can you talk a little bit more about what you mentioned this in the article, that that, I mean, this allowed you to be creative, and talk a little bit more about why you think medicine is an inherently creative field.
Yeah, thanks. They say medicine's an art as well as a science, and that art again is the art of communication, the art of, and I'm going to refer to Zucker's article again. She to paraphrase, she talks about how really what we're trying to do as physicians with patients is, what we should be doing is saying, okay, I encourage you to take this medication, not because it's the end all be all, but because it's the lesser of two evils, that it will help with whatever it is that we think you have, and that hopefully will prolong your life and improve your quality of life. But it's not an absolute, it's a relative thing. So how do you communicate relative risks to people? And it's so that you have to have a relationship of trust. And how do you build that relationship of trust? So there's a lot of skills and creative skills that are pulled, I think, they have to be pulled from other disciplines. Recently, I was having a challenge with communicating with a particular patient, and I leaned on my social worker to help facilitate kind of a little a communication sort of meeting. And so I think it's creativity in communication, and also in creativity in terms of the shared medical appointment, how to design it effectively. Now, some people would say, well, why is the physician running the group? I mean, shouldn't somebody at a lower pay scale do it? I mean, what are you going out and getting the veggie trays for? But I think at the end of the day, at the end of the day, it's a chance to do something that is different, and it is in that difference, it really can be refreshing. It was refreshing for me because I could see patients in a different context. And so then when I would come back into the exam room with them, ultimately, that relationship was strengthened, that trust was strengthened. And so it was, I guess, in a circuitous way, it improved their health, because then they were probably more apt to want to sort of take medication that I was recommending. Does that explain things a little bit? Or?
Well, I think so. And I mean, you're saying that, I mean, even in the shared appointment model, that wasn't the only appointment they would have.
Right.
They also come back on a one-on-one, a more traditional consultation, right?
Right, exactly. Yeah, yeah. And so, but the creativity is, for example, in the shared appointment, just per se, we would decide what kind of exercises we wanted to do. One of them was draw a picture of your future if your diabetes was under good control. And people would, we had crayons, we had paper. We actually had a couple of second-year residents in family medicine who got a small grant to be able to look at the benefits of doing some art therapy within the context of the shared medical appointment.
Interesting.
Yeah. And so we had little contests, true or false, little tiny prizes that we would give out, maybe pedometers or, something along those lines. So that's the practical creativity of running the group, and then also the creativity of how to communicate more effectively.
Great. And I mean, we've mentioned COVID a little bit. I mean, sitting here as we are in 2021, it's hard not to. I mean, this article came out in 2018, which
Right.
Feels like several generations ago.
Yeah.
I mean, whether it's about COVID specifically, or whether, I mean, this model has continued apart from, I mean, COVID and any respiratory disease linked to it. I mean, where do you think the model of shared appointments is now, and where do you think it's going? Where would you like it to go in the future?
Great question. Sadly, COVID has, as we know, increased loneliness and social isolation, and those two are in and of themselves a public health crisis for large groups of people, particularly the elderly. And it's been tough, and this sort of what do they say, preservation of self, preservation of species, really focusing on caring for each other is healthy. But it is hard to do with people that don't have access to technology. Now, you and I are communicating on Zoom.
Right.
Many meetings are held on Zoom, business meetings, 12-step meetings. If you can access it, it's not that difficult. But I think that's the link that has to happen right now, is helping folks of a certain generation, or who aren't used to this, even not even of a certain generation, people just haven't had access to the technology. Sure. That they don't know how to use it. They may have a cell phone, but they just don't know how to use Zoom or the internet effectively. So that's
I'm sorry, you mentioned in the article, I mean, that you're the sort of star of the article was having trouble, I mean, just getting a cell phone. And so, I mean, it's a good reminder that, I mean, as plugged in as most of us are, that there are still, a lot of underserved communities that one thing, that the cost of that, or just the logistics of that, is still a barrier to their own health.
Right. Exactly. Yeah. I mean, even now, there are folks that in order for them to have a video appointment with a physician, have to be brought somewhere so that someone can help them to set up the meeting. So yeah, it's tough, but hopefully speaking of creativity, hopefully we can come up with some creative solutions to help these folks to get plugged in. I know there's talk of the internet expanding more broadband. I've worked, I had the privilege of working on some Indian reservations. I was in the Navajo Nation in Northwest New Mexico, maybe in 2010 or 9. It was, I mean, the cell service there was horrible. I mean, some of these poor communities really struggle. So yes, we need to do something about just basic broadband for folks, and then teach them how to use it.
And talking about the shared appointment model in general, I mean, your work has been, I mean, with a certain demographic population working with diabetes. I mean, is there any interest that you've seen in, I mean, expanding in both the populations and the illnesses? I mean, where do you think this, I mean, if you want to call it a movement, where do you think it is right now?
Well, I know that Cleveland Clinic has done this sort of with different ethnicities, not Latinx populations, but English speaking, Caucasian. They've used that appointment to sort of be using that model to then I think they use it with their general physical exam appointments. So it has been used. I think getting traction though, it's really, you have to change people's minds, and you have to open their minds, and that takes work. I think that the people that have done shared medical appointments really can see the value in it. But those that haven't, I think, or just have been trained and socialized, speaking of physicians right now, in a certain way. So it's hard for some of those folks to understand, or maybe they don't even want to do that. They don't feel comfortable in that. So I look at it as one tool in the toolbox to help facilitate healthcare. And that was sort of the goal of that article was to talk about it from the point of view of physician burnout and also patient, enhancing the patient's healthcare outcomes.
This might be an unfair question, but if there were one piece of the puzzle, made up kind of one person in the chain that you would consider to be kind of a turnkey, I mean, would you think that this is something that patients have to get used to the most, or is it physicians that need to see the strength of this, or is this an administrative thing that our kind of model of healthcare has provided, that if kind of hospital or healthcare administrators were on board, I mean, do you think that one of those would be more powerful than the other ones to get this more widely adopted? And again, that might be sort of an unfair question.
It's a great question. And I've thought about this, and it's all of the above, I think. Okay. Yeah, I think so. I think patients do have a certain concept of what an appointment is. And again, there's many different stripes and colors and of the rainbow of patients as there are clinicians. So yes, but I think also, mainly, not mainly, but one of the big components is going to be finance. And sure. So how to get it to be paid for in our healthcare system. Yeah, I think it's all of the above. I think it's just realizing that it's out there, that it's effective. It can be effective for a number of reasons, and then education and time. But yeah, I think the pandemic it's been tough on this model for sure. Yeah, I mean, staying 6 feet, 6 feet apart in general, with this kind of model, and especially, like you said, it's possible, I'm sure, to happen over Zoom, but it's one of those things that's definitely better in person, I'm sure. Mm-hmm. Yeah. Well, great. I mean, speaking of experience, strength, and hope, Maureen, thanks so much for talking with me about this, and for just filling us in on a few more details of how this has helped, both your patients and you as a physician. Thanks so much. Oh, thank you, Lance. It's been a pleasure.